Assalamu alaikum. Good morning. Our today's lecture would be on calcium disorders, and as usual, we'll discuss 3 or 4 case scenarios, and with that, we'll try to understand how this calcium metabolism is regulated in the body, and what are the various organs involved, particularly the role of parathyroid hormone or parathyroid gland in the calcium hemostasis. Again, a beautiful view of a botanical garden, Sydney, which is near the Sydney Harbour. Our first case scenario is of a 20-year-old girl who was present in the emergency room complaining of convulsions or seizures or fits for the last 3 hours. While examining this girl, the house officer noticed that her voice had a croaky character during the examination or had a stridor. And when he started recording her blood pressure, he observed that her hands went into a spasm while he was recording that blood pressure. So with this just simple 2 observations, that presentation of a young girl with the fits along with this examination of her blood pressure leading on to the spasmodic contraction of the arms and fits, he reached a diagnosis. And then he decided to make out what further test he has to perform. Can you help us in deciding that what is the working diagnosis reached by this house officer, and what can be the 3 bedside signs you would like to perform to confirm this diagnosis? So what do you think? Now this is a very near classic manifestation of tetany, right? And this tetany results because of hypocalcemia, or to be more precise, because of decreased in ionized calcium level of the blood or in the serum. The signs which you would like to demonstrate would be Troisios signs and Shostak sign. And when you elicit the reflexes, the tendon reflexes are usually brisk in patients who have hypocalcemia because of increased excitability of the tissues. This is what Troisios sign is. How is it demonstrated? That you inflate a blood pressure cuff 20 millimeter above the systolic pressure, and keep it inflated for about 3 to 5 minutes, and what you notice would be carpopedal spasm. There would be flexion at the wrist, there would be flexion at the metacarpopharyngeal joints, there would be extension of the interphalangeal joints, and abduction of the adduction of the thumbs and the fingers, and this is also called as obstetrician's hands. So when you notice this, and this was a sign which was incidentally noticed by the house officer. This is what is called as Shostak signs, that you strike in front of the tragus, or in front of your in front of the ear, over where the facial nerve exits from the styloid foramen, and when you press over it, you would notice ipsilateral closure of the eye and twitching of the mouth, or division of the mouth to the same side. So this is again a sign of hyperexcitation. Now we know that the tetany results from decrease in the calcium levels. How this calcium level is regulated in the body, just a brief review of that, that the plasma serum calcium is regulated through the parathyroid hormones or parathyroid glands. There are 4 parathyroid glands lying, each one lying on behind the thyroid, each lobe. And what this does, that whenever there is a decrease in serum calcium level, this releases parathormone or parathyroid hormone from the parathyroid glands, and this parathyroid has 3 sites of action. Its first site of action is it's on the bone, its second site of action is on the kidneys, and its third site of action is in the gut as well, right? So what does it do? that parathyroid hormone increase would lead on to increased in resorption of bone or release of calcium, and it would try to maintain the calcium level. What does it on the kidney? In the kidney, it would lead on to decreased, reabsorption of the phosphate and increased reabsorption. So phosphate would be lost in the urine and calcium will be reabsorbed and retained, and again that would restore the calcium level. What does it do in the gut? In the gut, in combination with 125 hydroxy vitamin D3, it would lead on to increased calcium absorption from the gut. Now, this brings in another component in the calcium homeostasis, which is vitamin D. And this is how this calcium level is restored through action of parathormone on the bone, on the kidney, on the gut, and by the vitamin D, which is activated first in the kidney and then in the liver, and then finally this 125 hydroxyvitamin acts both in the kidney to reabsorb and on the gut to reabsorb more of the calcium. Another component for calcium homeostasis is again from the thyroid, but this time not from the parathyroid glands but from the thyroid itself, where thyroid C cells, they produce calcitonin. Now the calcium homeostasis is whenever this calcium level is decreasing, this stimulates the parathyroid glands, and this parathyroid glands leads to increased release of calcium from the bone, increased absorption from the gut, and increased absorption from the kidneys, and that's would lead it. But when the calcium level is quite high, what does it do? It then leads on to release of calcitonin. What does calcitonin do? It moves the calcium back into the bone, so there is increased deposition of bone. That's why this calcitonin is also used in management of osteoporosis and other bone disorders. This would reduce the calcium absorption from the gut, and this would reduce the calcium reabsorption from the kidney, and then would again restore the balance. Now this parathormone is an 84 amino acid polypeptide, which is released as a prohormone and then activated into its active form. This is the main site of its action are, as I said, the bone, gut, and the liver. This is the main hormone which regulates the calcium homeostasis, and the normal calcium levels, that is to be remembered, is 9 to 10 milligram per deciliters or 2.2 to 2.6 millimoles per liter. The same very homeostasis explained in a more elaborate form, but again depicting the various sites of action of parathormone, and then of course the role of calcitonin into the calcium homeostasis, right? Also note that this distal renal tubular reabsorption of calcium is very important, and tubular disorders like renal tubular acidosis may also affect the calcium reabsorption absorption and may lead on to the certain hyper or hypocalcemic disorders. Hyperparathyroidism, or lack of function of the parathyroid hormone or production or says its action. The most common cause of hyperparathyroidism is usually iatrogenic. Why? In most of the patients who undergo, if not most, many of the patients who undergo thyroid surgery, there is a chance of accidental removal of the parathyroid gland along with this thyroid, and some of the patients who have this parathyroid gland being accidentally operated upon during thyroid surgery may later on develop hypoparathyroidism and all the symptoms of hypoparathyroidism. The second the most common cause is idiopathic or autoimmune, for which we usually don't know the exact cause. Then there can be a condition called as pseudohypoparathyroidism, which is an autosomal disorder where the parathormone or parathyroid hormone production is okay, but there is a receptor defect in the tissues where the parathormone has to act. So that results in lack of action of parathormone, which results in hypocalcemia. But paradoxically, the parathormone level is not reduced, rather it is increased. There is another form of this hypoparathyroidism, which is called as pseudohypoparathyroidism. Now, this is the condition where you have some of the skeletal abnormalities which are peculiar to pseudohypoparathyroidism. You do have a normal calcium and parathormone level, but the skeletal deformities of pseudohypoparathyroidism are there. This would be maybe say genetically transmitted and not manifested form of pseudohypoparathyroidism. The target organ insensitivity to parathyroid hormone that in the bone and kidney, which are the main target organ for the parathormone, results in pseudohypoparathyroidism, and the manifestation would be in the form of hypocalcemia, hyperphosphatemia, because parathyroid hormone leads on to excretion, more excretion of the phosphate, and if it is not there, the phosphate is retained, and of course there would be elevated parathormone or parathyroid hormone. The pseudohypoparathyroidism usually may be resulting from some gene mutation, GNAS1 gene mutation, which is responsible for intracellular signals, and then there is a type 1 PHP mutation, which is transmitted as an autosomal dominant, and then there is Albright's hereditary osteodystrophy, which can be again hereditary or genetically transmitted. This is an example of a patient with Albright syndrome, or a combination of pseudohypoparathyroidism with various skeletal deformities. They do have a short stature and limbs. They are usually obese. They have a round and flat faces. The most peculiar thing is there is short fourth and fifth metacarpal bones, resulting in short fourth and fifth little finger and the ring fingers. Archibald sign is again when you make a fist, you have dipping of the knuckles. Brachydactyly, short fingers. They have potter's thumb. They may have some problem with the eyes in the form of premature cataracts. They may have some mental retardation, and another feature may be that on skull X-ray they may have calcification of their basal ganglia. The pseudo-hypoparathyroidism, as I said, is a phenotype of Albright's. There is normal serum calcium, no parathyroid resistance, and there may be some paternal GNAS gene mutation, but these individuals do have skeletal deformities as per pseudohypoparathyroidism, but they do have normal calcium and parathormone levels. This is just that how this pseudohypoparathyroidism manifests. If you notice, there is unusually small fourth and fifth fingers on both sides, and when you make a fist, you notice very prominent knuckle for the second and third metacarpal, but the fourth and fifth knuckles, they are dipped in because of the metacarpal being short. The various other signs which you can demonstrate, two of them we already demonstrated in the beginning. The one is Schaufstein, striking on the in front of tragus, leading on to ipsilateral twitching of the face. You can notice Strozio sign, where you elevate the blood pressure, systolic blood pressure above around 20 millimeter above the systolic for about 3 minutes, and you notice carpopedal spasm. Their reflexes are brisk. They may have laryngospasm leading on to stridor. Particularly the infants may present with convulsions, and sometimes they prolonged hypocalcemia for quite some time may also result in mental retardation. They may have skeletal deformities because of persistent hypocalcemia, and the bone being deformed because of not being able to properly resorb. The ECG would show a prolonged QT. You take the measure for the QT from the beginning of the QRS to the end of the T wave, and then a prolonged hypocalcemia can result in premature cataract and papilledema. This is a differential diagnosis of when you have a calcium level low. What we usually take notice of that is take four things into consideration: calcium, the ionized calcium, the phosphate, and parathormone. Since calcium is majority of it is bound to albumin, so the hypoalbuminemia would lead on to a total calcium being low, but the ionized and calcium level and phosphate and parathormone level would be normal. And that's why whenever you have a low calcium level, you simultaneously check for the hypoalbumin level and then do a correction that whether for a given albumin level this total calcium is okay, because the ionized calcium, which is actually responsible for parathormone release, would be normal. In patient with alkalosis, you may have primarily low ionized calcium with normal parathormone phosphate level. In vitamin deficiency, vitamin D deficiency, the calcium would be low, the ionized calcium would be low, their phosphate would be low as well, but their parathormone would be high. In patients who have hypoparathyroidism, their calcium would be low, ionized calcium would also be low, but their phosphate would be high and their parathormone would be low. In pseudohypoparathyroidism, as we already mentioned, they would have a low calcium, low ionized calcium, low high phosphate, and a raised parathormone level, paradoxically. In acute pancreatitis, again, there is an increased calcium sponification and hypocalcemia results, but this would result in a slightly elevated parathormone level. And in renal failure, again, since kidney has a major role in both one, reabsorption of the calcium, excretion of the phosphate, and then activation of vitamin D to vitamin 125 hydroxyvitamin, and this would result in a low calcium, low ionized calcium, but a high phosphate and high parathormone level. How do we manage hypocalcemia? Of course, in patients, since alkalosis leads on to worsening of the symptoms, you treat the alkalosis. Particularly the respiratory alkalosis can bring about the symptoms of tetany, so you ask your patient to rebreathe, exhale air through a bag. So you give them a shopper bag or a paper bag to be placed around mouth and nose, and they keep on rebreathing their own, and this would lead on to some rise in their, say, carbon dioxide level, and would create a situation of or undo the metabolic or respiratory alkalosis, and this would result in improvement. The second option is that you give them injection calcium gluconate, which is usually given slowly, 10 milligram in 10 milliliter over 10 minutes. So a rapid calcium infusion can lead on to sometime increased sense of warmth or maybe sometimes some arrhythmias. Magnesium usually, since it goes along with the calcium, so sometimes magnesium is also low, so magnesium sulfate may also be given. And finally, you give them 1 alpha hydroxycholecalciferol, vitamin D3, activated vitamin D3, which then leads on to an increased reabsorption of calcium from the kidneys, and of course its effects onto the bone as well. Our second patient is a 55-year-old male who has presented in emergency room holding his right flank. He complains of a severe right-sided lumbar pain. He's complaining of excessive vomiting. He's most of the time constipated, and again this time he's constipated for last 2 days. He has a dry tongue with vitals of blood pressure 150 or 110 millimeter mercury. Pulse is 110. On ultrasound of abdomen for kidney, ureter, and bladder, there was a radiopaque stone seen in the right kidney. So, what would be your list of differential diagnosis for this gentleman? Why is he having constipation and excessive vomiting? Why is he having hypertension? Why is he having this flank pain? And what would be the investigation which you would be requesting in this gentleman. Now this is a case of hypercalcemia. Why, we'll be talking in a moment, but this is how hypercalcemia manifests. The hypercalcemia can lead on to depression, the cognitive decline in the form of depression or anxiety, or patient may be insomniac, may be irritable, they may have some difficulty in swallowing, but more importantly, they may have palpitations, they may have osteopenia and osteoporosis, right? And similarly, their uh, ECG may show shortening of the QT interval. Now, the one of the causes of hypercalcemia can be hyperparathyroidism. So whenever you have hyperparathyroidism as a root cause of hypercalcemia, there are other causes of hypercalcemia as well, we'll be talking about in a short while. Now these patients may have, say, on their skull X-ray, the decalcification, which gives them salt and pepper appearance of the skull, will show in a moment. They may have a parathyroid adenoma. They sometimes have a metastatic calcification. By that means that the calcification in the non-osseous or non-bony tissues, which can be skin or soft tissues, or maybe the conduction to the heart as well. They have an increased tendency of developing peptic ulcer and pancreatitis because of a raised parathormone, leading on to increased bone resorption. Their bones become soft and fragile, and they lead on to osteitis fibrosa cystica, and there will be particularly more prominent subperiosteal bone loss. And this again, hypercalcemia and showing from hyperthyroidism would lead on to hypercalciuria and would result into nephrocalcinosis, may result in more tendency of formation of kidney stones, particularly calcium phosphate stones. They may end up in recurrent renal infections or renal failure, and similarly they may have a muscular atrophy. Now these are all symptoms which can be attributed to hypercalcemia. The hypercalcemia, as I said, can be considered as in two groups. You may have a hypercalcemia with a normal or elevated parathormone, and you may have hypercalcemia with a low parathormone. Elevated parathormone, non-parathormone, would be either as a result of a primary or a tertiary hyperparathyroidism, we'll be talking about in a moment, or sometime it may be because of familial hypocalciuric, that their kidney do not excrete calcium to the extent, and they results in hypercalcemia, but ionized calcium being normal, they may have normal parathormone levels, right? But on the other hand, someone who has a raised calcium but low parathormone, then you think of malignancy, where the metastasis of the bone is releasing on to more of the osteoclastic or osteoclastic activity of the bone, and resulting in more calcium from released bone. Multiple myeloma is another hematological disorder where this plasma cell produce some abnormal proteins, as well as this plasma cell invade the bone and lead on to lytic lesions, and this can lead on to hypercalcemia. Increased intake of milk and alkali, resulting in more calcium being absorbed from the gut, is milk alkali syndrome. Certain diuretics like thiazide diuretics can lead on to more reabsorption of the calcium, and it can result in hypercalcemia. Paget's disease is another one where there is an increased sensitivity of the bone, and there is an increased bone calcium release. Excessive intake of vitamin D can also result in hypercalcemia, and sometimes this Addison disease is also associated with some lack of effect of the parathormone, and can lead on to hypercalcemia. The hyperparathyroidism can be considered as in three forms: primary or secondary or tertiary, and sometimes malignant. Primary mean that there is an adenoma in the parathyroid gland which releases more parathormone, and this would result in raised calcium. Parathormone may be normal or high, phosphate would be low, and alkaline phosphatase would be high because of high turnover, and their urine would have urine calcium to phosphate ratio would be high, meaning by that the calcium more phosphate would be retained and calcium would be lost. But in secondary hyperparathyroidism, the calcium is low. Secondary mean that the primarily the calcium is low because of other reasons, which may be because of the less calcium being absorbed from the gut, or less calcium being reabsorbed from the kidney in renal failure, and maybe raised phosphate level. So this would then result in a low calcium would lead on to stimulation of the parathyroid hormone and results in a high parathormone and high phosphate and high alkaline level, and this urine calcium phosphate ratio would be low, and this is that primarily it's a hypocalcemia which results in an increased parathormone level. The most common example is chronic renal failure. In renal failure patients, there is the increased phosphate retention and more calcium lost, and this results in parathyroid being stimulated, and this try to compensate or regulate the calcium metabolism, and when it does not do, it may lead on. Now same very mechanism when it started as a secondary because of renal cause, but finally this parathormone leads on to and attains an autonomous say increase, or this secondary hyperparathyroidism turns into an adenomatous growth of the parathormone. Then this is called as a tertiary hyperparathyroidism, where the calcium tends to be high, parathormone may be normal or high, there is phosphate is also high, and their alkaline phosphatase. In patients who have malignant say hypercalcemia, their calcium is high and but parathormone is usually low or normal. Same as the case with the phosphate, which is low, and alkaline phosphatase is high because of the high bone turnover. Whenever you have a patient with hypercalcemia or raised calcium level, the first thing probably you need to do is screen him or her for a malignancy, metastatic malignancy to the bone. You do a chest x-ray, you do a bone scan, you do x-ray of the hands, you might have to do CT of the neck for detection of the parathyroid glands, and you probably need to rule out multiple myeloma, particularly in the elderly age group, by doing serum protein electrophoresis, by Banks-Jones proteins and immunoglobulins. And not to forget, another important cause of hypercalcemia can be sarcoidosis, where sarcoidosis may you check the serum ACE levels, but the reason for sarcoidosis to cause hypercalcemia is more activation of vitamin D to active form from vitamin D 125 hydroxy by the patients who have sarcoidosis. When you go for the imaging of these patients, the most classical thing is that the bone is resorbed, and there are say areas of decalcification, and particularly they appear as a what is called as salt and pepper appearance, as if I've sprinkled pepper onto the on your egg white, and this would give you a sprinkling appearance. An advanced form of hyperparathyroidism would lead on to so much of a local say resorption of bone from the calcium from the bone that it retains cystic transformation and may lead on to bone cysts, particularly in the younger individuals. This is another example of the bone being resorbed from the subperiosteal tissues, and this is that in an advanced stage, this is so much of bone is lost that it itself say becomes like more of a tumorous say structure with all the bone being gone, and these are called brown tumors. In management of hypercalcemia, this hypercalcemia leads on to a lot of post-diuresis. Hypercalcemia along with hypercalciuria would lead on to a lot of water being lost, and the first and foremost thing to do is rehydrate. Similarly, the shrinkage of volume would lead on to more of the ionized calcium being there, and this patient are likely to have the manifestation because of that. So Usually we rehydrate them in up to 4 and 6 liters of saline. The second thing is that you give them bisphosphonates. Bisphosphonates are the agents which leads on to move calcium from serum or blood from the extracellular space back into the bones, and this usually the most preferred bisphosphonates in emergency situation for treatment of hypercalcemia is primidonate. It is given in an injectable form, 90 milligram intravenously over. The other alendronate or zendronate, and there are so many other bisphosphonates available which can be used for minor hypercalcemia management or in patients with say secondary hyperparathyroidism. If you diurese them, again that would help in removing more calcium, and similarly the glucocorticoid steroids leads on to move calcium from the this blood back into the bone. Calcitonin or calcitonin again is an agent which we already showed that in calcium hemostasis the lead on to move back calcium from the extracellular space into the intercellular space and particularly into the bone. And finally, sometime for malignant hypercalcemia, you might have to go for dialysis. This Sinacel set is available, and it is an oral agent which inhibits the parathyroid hormone secretions by altering the calcium sensing receptors in the parathyroid. So that can be a drug of choice in patients who has to undergo say medical management of hypercalcemia, possibly because of the hyperparathyroidism as well as maybe in malignant hypercalcemias. This is again one of the say view in Botanical Garden in Sydney, and this is a replica of the indigenous people living there, aborigines, which have been forced into the jungles and have been, I mean, they are equivalent of red Indians in Americas. These are the people who were originally inhabited the Australia, and when it was discovered and the Western people came, they forced them back into jungles, and now they are being their work is being appreciated in various art forms in various museums. Our third case scenario is a 40-year-old female. She is known epileptic, and she presented with 4 months history of generalized muscular discomfort, particularly in her shoulders. The symptoms don't worsen in the morning, and with non-specific relieving factors. Her weight is stable. The examination reveals only mild proximal weakness in both arms and legs with preserved reflexes. She has some difficulty in raising her arms above her head or shoulders and standing up from a sitting position in the chair or in the bed. The subsequent investigation of this lady revealed a hemoglobin of 10.9, ESR was normal, her blood glucose and A1C were normal, but her calcium was markedly low, 7.4 milligram per deciliter. Her phosphate was okay, but alkaline phosphatase was borderline raised. So what's the possible diagnosis in this lady who is complaining of proximal muscle weakness along with some non-specific muscular discomfort? Now this is a classical example of osteomalacia. This patient's presentation with myalgia or muscle pain associated with combination of mild hypocalcemia, hypophosphatemia, and elevated alkaline phosphatase is strongly suggestive of osteomalacia. What happens in osteomalacia? This is the normal bone, and this is how this nicely calcified. But in osteomalacia, you have calcium being lost from the bone, making it more fragile and more, vulnerable to fractures. So whenever someone has osteopenia or poverty of the bone, that's what we call that, you may have 3 possibilities. Either This patient has osteomalacia, as in this are patients where there is a normal matrix but deficient mineralization. Or this patient have osteoporosis where it is deficient in matrix but calcium is okay and mineralization is okay. And then in hyperparathyroidism where you have a normal matrix and mineralization but there is an increased loss of calcium from the bone. I usually give an example of say this to understand this, that if you make uh, say pillar or something, and to make that pillar stable, what do? There is an inner scaffold of this iron or what कहते हैं iron rods or सरिया जिसको हम कहते हैं, and then you pour in the concrete in the form of this cement and all that. Now this your pillar can be weak if you have not had an enough steel or iron or saria being placed, and this would be deficient matrix, and this deficient matrix would make this pillar vulnerable to break and fractures, and this is what osteoporosis is. On the other hand, you had enough of this iron rods and saria and all that, but there is lack of cement into it or lack of calcium into it. This again would break, because of it would again be more liable to fractures. And third is that you had both okay, but somehow there is some kind of a process going on which leads on to some wetness and leads on to removal of this calcium from this, and there is a, to begin with it was the adequate cement and adequate, but this lead on to more of resorption. Now this is what hyperparathyroidism does to it, that this parathormone leads on to more removal of calcium from this, and this results in fractures or breakdown. So this is a simple understanding of how this osteopenia would result in either osteoporosis or osteomalacia or hyperparathyroidism leading on to bone weakness and fractures. The rickets and osteomalacia both are similar condition. Rickets is when it happens in growing bones in the young children, and osteomalacia when it happens in adult grown up individuals because of the lack of say calcium deposition. And this would lead on to pathological defects in the bone matrix mineralization, not the matrix but mineralization. The rickets, as we said, is occurs in the children and growing age group, and osteomalacia later on. The factors which leads on to this rickets or osteomalacia are diverse, but the end result is the quantity of unmineralized bone or matrix is say reduced, and this is what calls an osteoid. This may be as a result of deficiency of abnormal metabolism of vitamin D, the most common cause in pediatric age group. Various reasons for vitamin deficiency: lack of exposure to sunlight, lack of vitamin D in diet, something wrong with the activation of vitamin D 1 to D125 hydroxy form either in the kidney or the liver. So kidney and liver disease can be responsible, right? So there are various reasons. Similarly, the phosphate depletion can also result in say, because phosphate is the main stimulatory hormone for the parathormone. And similarly, chronic metabolic, as we discussed in the renal tubular acidosis, may lead on to defective reabsorption of calcium from the kidneys and results in hypocalcemia and tetany or osteomalacia. This is the list of causes, as we said, either inadequate synthesis in the skin, low diet intake, malabsorption, defective 25-hydroxylation in the patient with primary biliary cirrhosis, liver disease, or some anticonvulsant can be reason for that. 1-alpha-hydroxy takes place in kidneys, so kidney disorders can be responsible for that. The interaction with fluorides, aluminum bisphosphonates, which leads on to inhibition of mineralization, and similarly some inherited disorders may be responsible for that. Most of the patients who have osteomalacia or rickets, they present with the pain in bones or in the body, backache, muscle weakness, proximal myopathy, or inability to stand up from sitting positions. They will vertebra may collapse and lead on to kyphosis, and sometimes they may be in elderly may lead on to loss of height as well. There may be deformities, there may be stress fractures. They have difficulty in walking and rising, and sometimes they may have a battling gait as well. So this is the differences between the rickets and osteomalacia. I said rickets is more common in the growing bones. Skeletal pain, deformities, both legs are common. They are susceptible to fractures. They have weakness, hypotonia, overall growth is retarded. They may have a prominence of costochondral junction in the form of ricketic rosary, and they may have a Harrison's groove, which is indentation of the lower lobes because of the pressure by the contracted diaphragm with each breathing. And similarly, they would have hypocalcemia. But in osteomalacia, the signs and symptoms are not as dramatic. They may have vague, diffuse skeletal pain, sometimes bone tenderness. They have a tendency to fractures. They do have a gait disturbances later on, and more prominently, they present with proximal weakness and hypotonia. The less test you perform, that invariably they would have an increased serum alkaline phosphatase because of increased osteoblastic activity. Plasma calcium usually is normal, but in decreased it would be decreased in severe cases. But the more importantly, the serum phosphate would be low, and they would have a low 25 hydroxy vitamin D levels. Their x-rays, since the veins are soft, they tend to bow quite a bit. This probably had already fracture, and at various areas there is an recurrent fractures which have a poor healing and manifested as loser zones. These are the various examples of these loser zones, and this is again because of this. Usually these losers are at the sites of where there is a soft bone, and overlying it is a pulsating artery, and with even the pulsation, slight pressure of this pulsating artery makes this bone vulnerable to have a, say, fracture line. And this codfish vertebra, again, this is the appearance given to that, and then this tilting of the pelvis, indentation, vestibular stress fractures is likely. These are various examples of loser zones in the lateral, say, border of the scapula, subscapular artery, at the upper rami of the pelvis. Again, in the one of the compressed vertebra as a result of a being getting softened. Again, other loser zones, various loser zones. So what do we do with these gentlemen? That we might have to rely on more specific diagnosis, like going for an iliac crest biopsy, particularly if biochemical tests do not help us in making diagnosis, and sometimes serum fibroblast FGF23 may be elevated in tumor-associated osteomalacia. The treatment would depend upon the underlying cause. We have to treat it with vitamin D supplementation. We have to give phosphate supplements if required, calcium supplements for isolated calcium deficiency, and bicarbonate if chronic acidosis or renal tubular acidosis is the cause for hypocalcemia. Vitamin D is usually given dose of 400 to 800 units per day for nutritional deficiency, but if we are treating, say, deficient state, higher dose or parenteral administration in the form of intramuscular injection may be required. Calcitriol or alpha calcidiol is this activated vitamin D3, 1-alpha hydroxylation in patient with CKD or those who have vitamin D dependency, and hypophosphatic rickets and osteomalacia would also require vitamin D supplementation. Treatment may also need to be for correction of recurrent fractures. We might have to stabilize their vertebra or spine with the spinal supports or braces. They have to have an increase in their calcium intake in the form of more intake of milk, yogurt, and cheese. They should take more dark green leafy vegetables, and fish and seafoods are also rich in calcium. So are the almonds. You regularly monitor their serum calcium level, alkaline phosphatase level, and you do screen for hypercalcemia, because over treatment can result in hypercalcemia, which can be again detrimental for your patients. Normalization of the alkaline phosphatase is a good measure of that patient is healing and there are no more further bone loss happening in this patient. Thank you very much for your patient listening, and we'll be continuing on with the adrenals in the last lectures. Thank you.